Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Today, we're tackling an increasingly important topic, caring for older adults with rheumatic disease. Depending on where you look, anywhere from 20 to 40% of the patients that we see in rheumatology clinics are 65 years of age or older. With the aging of the U.S. population and the fact that people are living longer lives, the number of older adults in our clinics is only expected to rise over time. Older adults present with particular challenges that need to be addressed in order to provide comprehensive rheumatology care. Joining us today is Dr. Namrata Singh, a leader in geriatric rheumatology, who will discuss some of the most pressing issues in the field, including why older adults require a different approach to care in rheumatology, the impact of multimorbidity and polypharmacy, and how to manage these patients. We talk about frailty, what it is, how to assess it, and how to prevent it. She'll describe late-onset rheumatoid arthritis, how it differs from traditional RA, and why it's often underdiagnosed and undertreated. She discusses the 5Ms framework, which is a geriatric care model that helps clinicians focus on what matters most to older adults. She discusses palliative care in rheumatology and why it's not just for end-of-life situations. And finally, we'll discuss how to improve shared decision-making with older patients and their families. Dr. Namrata Singh is a rheumatologist in the Division of Rheumatology at the University of Washington. Before moving to Washington, she was faculty at the University of Iowa, where she also completed her Master's of Science in Clinical Investigation. Dr. Singh calls herself an onco-geri-rheumatologist, with her research focusing on the care of older adults with rheumatic disease who develop cancer or those with cancer who develop complications of cancer therapy. She's currently funded by a NIAMS K23 grant, well, at least for now, and the GEMSTAR Award from the National Institute on Aging. And with that, let's get on with the show. Namrata, welcome to the show.
Good morning, John. Thank you so much for having me. I'm super excited.
Yeah, I remember the first time I met you was at the Knowledge Bowl when you were part of multi-year champions at the University of Iowa. Now you're running the Knowledge Bowl. It's great to see that.
Oh, thank you so much, John. Very fond memories of those days indeed. And definitely, Iowa has a very special place in my heart for several reasons, and one of them being the Knowledge Bowl.
Yeah, great. And one of the things I didn't know about you is that you have a particular interest in the care of older adults, and especially older adults with rheumatic diseases. My question to you is, as a rheumatologist, why should I care? Why is it important to learn about the particulars of caring for older adults?
That is an excellent question, John, and definitely something that a few of us who are identifying ourselves as a special interest group of geri-rheumatology or geriatric rheumatologists feel that that is a question we've answered in our minds many months, years ago for whoever we are thinking of. But the heart of this answer is that we are an aging nation. We are aging as a country and we are aging globally. And just if somebody wants to rely on numbers to have me give back up to my answer, is that in 2023, approximately 55 million adults were older than 65 years living in the US. And a landmark projected is that in 2034, we project that older adults who are 65 and above will be surpassing the number of children in the US. About 23% of older adults will be in 2034 more than our children. So I think that just gives a situation a gravity and give us a pause that just like rheumatology, there is workforce shortage in geriatrics as well. I'm not saying that we need to become geriatricians at all, but I'm just saying that there's not enough geriatricians probably out there. And for us to, in rheumatology as well, start thinking about these principles while caring for our older adults will really help go a long way for our patients.
Yeah, and I guess also some of our rheumatic diseases seem to be more common in older adults as well.
Absolutely.
So they make up a larger proportion of our population. Certainly, I don't see as many older adults in my pediatrics practice, but for my adults, certainly they tend to be a little bit older. So, why is it important to be aware of the older adult patient? What unique challenges do they present?
Yeah, I think there are quite a few, several unique challenges which make them a different population or understanding a few different principles to guide our care. Several of our diseases in rheumatology, especially when it comes to an older adult, have principles such as multimorbidity, polypharmacy, which I'm happy to elaborate next. But just to name a few, multimorbidity, polypharmacy, and then even atypical presentation of rheumatic diseases in later ages. Several geriatric syndromes are prevalent in older adults. So, all of these factors make it very important that we understand what these mean and how can they interplay while I'm making decisions maybe on their DMARD therapy, on their disease modifying rheumatic drug therapies. So, for example, now to talk about multimorbidity, what do I mean by that? It's the coexistence of two or more conditions in the same individual. And then just to make sure I'm not talking about comorbidity here, and the inherent difference between the two being multimorbidity is a more holistic, patient centered plan, is how I think of it, and versus a comorbidity by itself hinges on something as an index condition and
Mm,
everything else around the patient being a comorbidity of the patient. So, for
mm,
example, patient you and I might be treating with rheumatoid arthritis, we think rheumatoid arthritis is a index condition and maybe their osteoporosis is their comorbidity. But if you were to take a multimorbidity approach, you would say maybe the person has two or more conditions. They have rheumatoid arthritis and osteoporosis, maybe cardiovascular disease, etc. So that just makes it a different concept that a lot of older adults will be having by the time they are 65 or older. Polypharmacy is something I talked about, which is the concurrent use of five or more medications. And it's prevalent in patients with rheumatic diseases. Like if you're thinking about somebody with rheumatoid arthritis, more than 50% of them who are 65 and above have polypharmacy. And this is excluding the DMARDs. So these are impressive in numbers. And then late onset rheumatoid arthritis, or LORA, as is sometimes being referred to in the literature, is not maybe the same garden variety RA you and I are used to looking at and calling out as rheumatoid arthritis, has its own nuances. Geriatric syndromes is what I mentioned as well. These are conditions that are prevalent as one ages, but not necessarily fall within a specific box to call it its own disease. So the way I think about, these geriatric syndromes, a few things that come to example are frailty, falls, social isolation, visual cognitive impairments, sarcopenia. And the factor that why you and I should be maybe talking about this again today is that all of these things have multi-directional relationship, right? So one thing will drive other versus and back maybe impact the first thing to begin with. There are interactions between these different issues, and that will really help define a person's resilience and being able to bounce back from different conditions over time, different stressors over time. So I think this is a very unique population and has unique challenges.
yeah. One of the market differences between pediatric and adult rheumatology that I see is, as you mentioned, multimorbidity. Children most often just have their rheumatic disease and nothing else. And for adults with rheumatic diseases, and especially as they accrue more diseases as they age, multimorbidity seems to be an increasing issue. You mentioned a little bit about this late onset RA, which I'm not as familiar. Can you talk a little bit about how it may differ from regular RA?
Yeah, absolutely. So, would highlight some of the work my colleague Jiha Lee is doing around this concept. And this is basically somebody who's been diagnosed with rheumatoid arthritis, but are older than 65 at the time of disease onset. And the differences being that sometimes it's not as much of a small joint involvement, but also not as much of a female predominance as well that we are used to with rheumatoid arthritis. May almost can be even distribution, as well as the treatments that it entails is very different as well. As you can imagine, somebody who's 65 and above, maybe the treating rheumatologists are very shy about giving them biologics or DMARDs, even though we know that their disease activity warrants it and they have failed other conventional synthetic treatments. And then what we've seen is that more and more of these patients get treated with more steroids in lieu of avoiding BDMARDs or biologic DMARDs. And as you and I will probably very easily empathize, that's probably more harm done than help for these older adults who already have probably diabetes or cardiovascular diseases, etc. So it is another set of entity to make sure we recognize and treat more appropriately.
Great. And you mentioned some of these geriatric syndromes
Yeah.
that often are seen in our patients with rheumatic diseases and in older adults. You mentioned frailty. That's something that I've been hearing more and more about. I still can't necessarily define it or sort of know what to do about it. Can you talk a little bit about that?
Yeah, absolutely. And it's a concept or issue very near and dear my heart because really that's what gravitated me towards learning and incorporating geriatric principles in my care. As somebody who leads a rheumatology oncology clinic at my center, as I started building my patients in a panel in the clinic, I realized that, of course, I'm seeing a lot of adults with cancer. Either they have prior rheumatologic disease or this is because of de novo complication of immunotherapies for cancer. I did realize that I'm seeing more and more older adults in my clinic. And I was feeling that there is a bit of a disconnect in how well I connect with my patient just because it was very much gravitating towards an older adult population. And just so happened, I listened to the 5M's talk, which I know we'll get to in a second, by Dr. Una Macrease at ACR 2021. And we connected, and she's been an amazing mentor since then. And frailty in specific is because I think when I started seeing these patients, I was like, what is it missing? That missing link that I was thinking of is where I saw that a lot of my patients who were coming in the clinic were frail. And what do I mean by that? Frailty is defined at best for now is as a vulnerable state where maybe is because of an physiologic decline as we age, patients are more vulnerable to stressors, and
Mm.
which puts them at higher risk of adverse health outcomes. You can put any other outcome of your interest or that you care about. Like, of course, we care about mortality or falls or other. The one thing about frailty, and might be the reason why you're like, I'm listening more about it, but I'm still not sure I understand it, is that frailty has inherently been challenging to define, mainly
Mhm.
because, if you can't measure something, how are you going to define, right? Like we want something measurable to be able to say, yeah, I understand what this is. And in the frailty literature, the struggle has been that we are still finding ways of defining and using what is the right tool to measure frailty. But so far, there's been tremendous work done, amazing work by some many colleagues in the field, one of them being Dr. Freed, who developed the Freed frailty phenotype, which is one type by which you measure frailty. And there are 5 things that you will measure in the clinic when you have the patient in front of you, some of them being the energy level, the gait speed that they have, physical ability, exhaustion, etc. So 5 of them, unintentional weight loss, if of the 5 criteria, 3 are met, you can call the patient as frail.
Are these like surveys, like what is your energy, or are these things that you measure in your clinic?
A
Like,
mix of both, yeah. So
mhm.
there are questionnaires, there's a grip strength you can measure, and then exhaustion, weakness, walking speed. You will want to walk the patient and see what speed they have. So yeah, it is much more hands-on. You have to measure these things in the clinic and do deliberate efforts to measure them. And if you have 1 or 2 of these criteria, you're called pre-frail. But in the opposite side is another concept to measure frailty, which is called the cumulative deficit model, where it's measured as how many deficits, so to say, you've accumulated over time. And that's another one that is very commonly, this was developed by Dr. Rockwood. So it's also sometimes called by the Rockwood Index. But then there are several mutations of it, like there's one called claims-based index that I've used by Dr. Kim at Harvard. And then there's the VA frailty index, or VAFI, which is another, taking that concept and applying it and making an index to measure frailty. The thing about these indices are that if you have electronic medical record in front of you, where you know what conditions a patient has been diagnosed with, or if they are cognitively impaired or not, you can calculate the index versus the frailty phenotype, where you have to measure these things in the clinic, right?
Got it.
So that's where these two concepts differ a little bit. One is on accumulated deficits over time. The other is actually measuring few physiologic things in the clinic. So that's what frailty is mostly, as the framework of thinking about it. The one thing I would want to highlight for the listener is that older age itself is not frailty. I have seen very robust older adults in my clinic, and by robust is the opposite, like robust is not frail, right? So older adults who are very robust in the clinic versus younger individuals who are so frail.
Yeah.
So that's something, as a rheumatologist, one gets humbled every day, is that aging is an art, and it's not that older age is itself a frail state or a sarcopenic state. And that's what we hope. And our patients in rheumatology, they tend to develop these, so if I were to call them deficits, earlier. And that's where our goal could be proactive and enabling our patients that, hey, there's some ways we can do, as we call, age better, age like fine wine. So that's where these concepts and recognition can come into play. And in patients with rheumatoid arthritis, for example, there's a systematic review. I think they had about 16 studies where they showed prevalence of frailty in RA was 33%. And with a mean age was 63 years. So this is relatively young patient population. And lupus, the numbers are even more humbling. The range can be of what prevalence of frailty was measured in a particular study. Again, as we talked about, will depend on what measurement tools were used to define frailty, but can go from as little as like maybe 6% to as high as 80% of the cohort can be frail. And this is, of course, as we can imagine, a lupus patient population with mean age of 36 to 48 years, right? So age is not frailty.
So it's interesting. So it seems like age is a risk factor for frailty. I'm sure the
Right.
older you are, the more likely you are to be frail, but also rheumatic diseases seems to be an independent risk factor for frailty as well. And if you combine both, that's even
Right.
worse.
Right.
So the natural question is like, well, is there anything you can do about it? Both when you're diagnosed with frailty, that's one thing. And also, as you mentioned, what can you do to try to prevent frailty when you're younger and don't have frailty yet, or you're in the pre-frailty condition that you mentioned?
Yeah. So I think the biggest data on mitigating or intervening to prevent frailty is really coming from the care of older adults, maybe more from geriatrics. So what I'm saying is not necessarily data that is from rheumatic disease population,
Okay.
but hoping we'll get there. We are working towards getting there as well. But the interventions that really are, I think of it in my everyday life, is like things that your mom told you when you were younger and you were like, yeah, what does mom know, right? So literally coming full circle again, what my mom said was right. Stay active, be very careful about your nutritional diet, high protein rich diet. And I think that's the other part of it, as you and I as physicians can do, is making sure the medications on their lists are not contributing towards frailty. So steroids or glucocorticoids can be a big one, is right. We know how they affect the bone. They put you at risk of falling. They put you at risk of fracturing, with concerns about muscle mass and muscle strength, and sarcopenia can develop. So minimizing or de-prescribing, as we call it, when things are not really needed and can be de-escalated. So really the three big things I feel we have most data on for frailty in mitigation would come from physical activity, nutritional interventions, and de-prescribing.
Got it. So exercise, nutrition, and deprescribing. So exercise, certainly
even strength-based, even more than maybe high
Right.
cardio aerobic.
Yeah.
Um,
That's one of the things that I've been in listening to other podcasts, the importance of maintaining strength, that as you get older, you just get weaker and weaker and weaker. And that kind of
right.
scared me because I'm sort of a midlife, middle age. I don't know. But certainly I've started in a weight training to try to keep up my muscle mass and hopefully keep that as I age. In terms of your nutrition, it sounds like you discuss protein as like
Yeah.
increasing protein intake. Is that the sort of the most important nutritional thing you can do?
I think, and also, of course, maintaining that ties together with maintaining a certain more appropriate weight as well, right?
Mm,
Because as you and I will probably counsel, especially our osteoarthritis patients, right, is all excess weight on the knees is going to may probably eventually increase the pain that you might have eventually with walking or standing, etc. So protein intake maximizing will help that maybe you're not putting too many carbs or fats on the plate, but everything in moderation at the end of the day is what it is, that it will probably help in maintaining and minimizing the impact of frailty in life. But I totally understand some things are easier said than done, but at least even knowing what goals should be ahead of us is very important, that increasing protein intake and maybe moderating the carbohydrate and fat intake can be one way of just helping my joints in general as well. And if my joints feel better, maybe I can move better. I can be more mobile. So I think they are all intertwined in ways we probably are not appreciating.
yeah. It's so interesting. I recently recommended my mom try some protein shakes because I feel like she doesn't
Yeah.
get enough protein in her diet. And
And
I want her to stay healthy for years and years to come. I wonder if you have any data about like the SLGLT2 inhibitors, and do they have any role in either preventing or addressing frailty, because they may address, some of the weight that you mentioned. Is
right.
there any data about these new medications and their roles in frailty?
No, that's an excellent question. And actually, I have not been involved in this work, but I definitely know there's several investigators, especially from Europe, that I've seen papers from where they are literally examining these associations. And if I'm not mistaken, there's been some studies even in high profile journals like New England Journal of Medicine where they are describing with weight loss is one aspect, but sadly, some of these might also be related to muscle loss, some of these
Yep,
drugs, and be actually maybe be very mindful, especially when on these drugs, of not losing muscle. Weight loss is what your goal is, but make sure you're maintaining and doing activities to maintain muscle, because some part of that weight loss could be muscle loss. And that's
great
not
point.
what we want during the process of weight loss.
Yeah. So you mentioned exercise, nutrition, and deprescribing as ways to try to prevent frailty. Are those the same prescriptions that you would recommend somebody that is frail? And can somebody become robust using your vocabulary once they are diagnosed as having frailty or being frail?
I think definitely the pre-frail is a very good window of being able to intervene. The data of how many people go from frailty to robust, I'm not sure it's as helpful to know that, or as strong that yes, that reversal happens. That reversal is possible, but it's just more difficult than being able to intervene at the pre-frailty part and getting them backwards from there than actually once you become completely frail. But
Interesting.
absolutely, some depending on what factors contributed to being frail, like if there were, it was maybe because they couldn't do a hand grip or walk more because their rheumatoid arthritis prevented when you were making those measurements. And while you, with your right treatment, you are able to, so to say, fix that, right, for the patient. Yeah, you, when you remeasure them, they're going to maybe be pre-frail at the next measurement. So really it depends on what contributing factor led to frailty. But I focus, I think, recognizing those pre-frail populations and intervening there is probably where the most effort might be utilized and be helpful.
Fantastic. Let's move on a little bit. You mentioned the five M's, and I remember from your talk at the prelim course about the five M's, and I wrote them down. Can you talk a little bit about what they are and why they're important?
Yes. And as I said with Dr. McCrease's talk, that's the first thing that was my exposure to learning the geriatric principles. And These 5Ms were developed and endorsed by the American Geriatric Society, or the AGS, as well as the Institute for Healthcare Improvement and the John Hartford Foundation. So these agencies came together to develop these. And this is really a framework for how to guide the care for older adults. And the 5Ms stand for mind, mobility, medications, multi-complexity, last but certainly not the least, what matters most to the patient. And overall, these, if you are developing or framing a visit around these 5 concepts, you probably are covering much of their care as well as focusing on their overall health is the goal.
So can you give a little bit more detail about, just briefly, each one of these 5Ms and how you would actually address it in your clinic with patients with rheumatic diseases?
Absolutely. So the first M, let's start with mind. And under the M of mind come 3 Ds, which are dementia, delirium, and depression. And really the idea is to make sure that our patients with rheumatic diseases can have cognitive impairments even at a higher rate than the general population, or be even earlier onset that you would think a general population might be affected with. And then at the same time, there's plenty of evidence to suggest that there are some modifiable risk factors, such as cardiovascular risk factors, pain, sometimes driving the cognitive impairment, and that can be reversible. So at the same time, understanding their mentation is super important under the making sure that the delirium and other signs of it developing are being addressed. And at the same time, maybe medications or other things that are contributing to this are taken care of. Under mobility is something that we talked about a little bit in the talk about mitigating frailty, for example, is how important mobility, assessment of gait, balance, and fall injury prevention is for our patients. I think some of our patients, especially older adults, feel that this is very important because it's their marker of independence, not being reliable on others for mobility and everything. So making sure that we are focusing and trying to recognize anybody at high risk for falls and intervening earlier than later, once the fall has actually happened, would be crucial. And again, once a fall happens, for example, a cascade of maybe more adverse health outcomes are more imminent than they could have been, and they could have been prevented by preventing that one fall.
Yeah, just a short story. My grandfather just suffered a femur fracture
Oh, I'm so sorry to
that
hear that.
required surgery, complicated by mini stroke, long hospitalization, and now he's just going back home. So I totally hear you about preventing falls is such an important issue for older adults.
Absolutely. And I'm so glad that he's doing better and is making way home now.
Yep.
So that was the M of mobility. And then touching upon the next M of medications, again, as somebody who started career, so to say, in my research career, pharmacoepidemiology, and how can we be very good about making sure that we are optimizing the benefits out of our drugs and minimizing the risks. Again, the same principles apply for medications is optimal prescribing, mitigating and minimizing polypharmacy, de-prescribe when you're able to, when you can, and just assess, like, is this a medication burden that person is coming in with? So, for example, at the ACR talk, an example I presented was of a prescribing cascade that can happen. Is you gave one drug, it led to another symptom that was thought of as a disease, another disease, got another prescription, and the cycle continues and the patient spirals down at the end of the day. So the ways to make sure we are optimizing medications are understanding that if there is another abbreviation, I apologize, but potentially inappropriate medications or PIMS, as my AGS talks are during when we attend them, is very important. So these potentially inappropriate medications, I'm sure you won't be surprised to hear, are prevalent in patients with rheumatoid arthritis, with patients with lupus and other rheumatic diseases. And some of them can be like the benzodiazepines and then gabapentin potentially, or opioids, right? So just always reassessing and doing our medication reconciliation when our patients come in is important. Multi-complexity is where we talk about taking care of a patient as a whole and not just as one individual with rheumatoid arthritis, for example. They have social complex needs, psychosocial, behavioral needs that need to be and drive their care of any disease that you want to manage. And the first thing that you might be thinking in your head is, Namrata, I can barely take care of their rheumatologic drugs and rheumatologic issues. Where am I going to have the manpower, superpower of addressing other complex issues?
That was going to be my next question. You,
And,
you you hit it right on the head.
yeah, I think it's just they tie so well together. It's like, how can I do all this, right? So at the same time, I think that's where it really is a team effort, and making sure your complex patients with multi complexity are dealt with a team that's very engaged and well equipped with all the necessary tools to treat that. And that could be your physical therapist. We talked about falls and assessing, and somebody's at risk of falls, physical therapist comes in. Maybe there are patients who would really benefit if within your network you have the ability to have them see geriatrician. Sometimes pharmacists are a big blessing, right? In terms of maybe scan for PIMS and whatnot. So team can be as broad as you could have and can gather. But then hitting the last M is what matters most, which can be sometimes almost foreign concept sometimes, because not something I grew up thinking of in my medical school or other training, is really all about what matters most to the patient and eliciting their goals of care. As you can imagine, they evolve over time, and making sure that you're prioritizing what their goal is more than just having your one goal of treat to target and low disease activity or DORIS remission, whatever your goal might be, just making sure that aligns with your patient's goal as well.
Got
So
it.
that was a whirlwind about 5 M's.
The five M's. No, you got through them all. So when thinking about these, you mentioned some of the potential team players like physical therapists, pharmacists. Do you see these patients in like multi-specialty clinics where everybody's there, or should that be the goal? Or in my center, we don't have that. So how do you recommend like coordinating care between
Yeah.
all these specialties?
And I'm right there with you, John. I don't necessarily have them all in my clinic, but at the same time, now I know that these are within the physical therapy department. This is my go to person who understands what are the patients coming from my referrals needing, and most of them. And then I understand, I read their notes, and there's a very good flow of communication at this point between them and me. And we are on quick Epic messages, Epic chats. If the people who have Epic system probably know what I'm talking about. And then
Better for worse, yes.
and then the pharmacist in our clinic is amazing. And she's like usually a message away as well that, hey, Net XY, please can you take a look at this patient's chart? And I'm concerned about the many medications they are on that are potentially causing some of the symptoms they came to me with. So that would be an amazing quick care co-management model that potentially we should think about and actually move our care towards, because this is going to be the need of the future.
Yeah. I see it all the time in my older adults is like they're on a ton of medicines.
Absolutely.
And I, as the rheumatologist, don't feel empowered to like decrease or stop any of them because I'm not sure why they were prescribed, like you mentioned, gabapentin or I don't know, potassium pills or
Right.
God knows what else. And like, is there a real indication and can you stop it? So I like the idea of a pharmacist who can objectively review their medications and help out. Because sometimes, even, I guess, if you're not trained in geriatrics,
Right.
polypharmacy may not be one of the things that you think about, right? You
Exactly.
may address patients like, well, they have hypertension and they have diabetes and they have heart disease and they have RA, and we're just going to put them on all the medicines for each of their diseases rather than sort of have a broad mind about, as you mentioned, multi complexity and multiple diseases going on at the same time while their quality of life.
Absolutely, John. And as I'm sure you're aware, the CMS is going to be releasing the policies about age friendly care being a priority of theirs. And any of these things that we are discussing will become more and more important, and it will actually be linked to reimbursements and whatnot.
Wow.
So I think now is the time to spread the word for sure.
Good to know. So, in that sense, how do you think about training rheumatologists to be able to manage older adults?
Yeah, I think some of these things of incorporating these age friendly principles, a low hanging fruit is what probably, for example, the American College of Rheumatology has already started with, is giving a platform for these aging focused principles being discussed and presented at our national meetings, at our didactics in each institution, because not everybody is able to go to ACR every year or there are missed opportunities. So if there's something presented at each institution, at meetings and conferences, and then also having good robust collaborations and partnerships with our geriatrics colleagues and seeing what's being at the forefront of caring for older adults that can be very easily probably imbibed in rheumatology is another one. And then for somebody who's one of the trainees, if they are interested in doing research in aging, it would be remiss of me to not mention this mechanism called the GEMSTAR, which is Grants for Early Medical Surgical Specialists Transition to Aging Research. What it really
Mm.
means is the NIA or the National Institute on Aging really wants subspecialists from other fields to think about and care about and collaborate with geriatricians, for example, to work towards understanding and how can we best provide care for older adults. And the mechanism is called GEMSTAR, but it's equivalent of an RO3 where applicants are provided, they come up with a mentorship plan in learning aging principles. They come up with a research proposal around this to what research proposed is going to help take care of, like, for example, mine talked about older adults with rheumatoid arthritis and cancer. And I know some other colleagues in our rheumatology group who have been a part of this. So I think research specific, this might be a really good mechanism to look into. Education wise, we talked about the conferences and didactics and making case based approaches also in regard to this. So I think few different ways to incorporate, but and palliative care is another thing that I think in rheumatology is not as appreciated, but would be good to start having trainees be involved with some palliative care models and how to discuss those cares during their routine care, especially for patients who might be needing it the most.
So, give me some examples about sort of the role of palliative care in caring for your patients with rheumatic diseases.
Yeah, so I think the biggest credit to give for bringing palliative care information and knowledge, I think in rheumatology, I would say that Dr. Young in University of Michigan has been amazing in helping us with that. And the idea is that palliative care is about giving patients the best symptom management and goals of care achievement, where, maybe the primary focus of your treatment is not like just focusing on one underlying treatment scare, but it's really about what's your goals of care and how can we give you the best quality of life. And as you can imagine, and I think again, I hope I'm not misspeaking, but a lot of the first person I think of is somebody with systemic sclerosis, right? Like it's just the disease has huge burden of care. And something to think about is maybe palliative care could come earlier in the treatment and not
Mm.
to think that palliative care is end of life care, right? Like that's the one thing we need to make sure we are moving our care towards is palliative care can come earlier and not only when they're end of life. Some models to think around that.
How do you think about shared decision making with older adults that may have some elements of dementia or maybe not?
Yeah.
And often they're living with other family members. They may have different goals for their care. How do you approach that in your clinic?
That is super important. And the one thing to think about is engaging everybody. So if you can engage, first is making sure you acknowledge them and engage them. By them, I also mean like not just the patient, their families and caregivers as well.
Hmm.
Half the time, I think the battle is that they don't even feel seen, that they went to the visit and they were just ignored during the whole conversation. So something to make sure you're engaging them because they are the ones who probably brought the patient to your appointment to begin with. And then at the end of the day, the other thing to keep in mind is, as I said, the what matters most to patients is important. Like, for example, from my clinic would be somebody who has cancer and they have, let's say, metastatic melanoma, and their goal of care is to maybe make sure the melanoma goes away. But now they've developed this really horrible inflammatory arthritis from the immunotherapy they received to the point they can't get out of bed to go get that drugs infusion, right?
Oh my
Now
goodness.
the oncologist is like, Namrita, can you see this patient 2 days ago, 10 days ago? And I'm like, It doesn't work like that, right? First of all. But now that the patient is at the brunt of all this, right? They want to maximize their lifespan, but they also value quality of life. So that's where these conversations come in is, hey, we want to give you that goal of care as well, achieve that goal. But at the same time, maybe we need to step back for a second, make sure we optimize your arthritis, get it under control to the best I can. And then so you can walk into the clinic and get that infusion again. So eliciting that goal and making sure if at any point it becomes, I don't care about these infusions anymore. All I want to do is spend some time with my grandkids, see them grow a bit, and that will be a good life for me. So just goals of care elicitation becomes important.
Awesome. What are the big questions that remain in the field of geriatrics and managing older adults? What sort of research is being done?
Yeah, I think there are so many questions. We are only at the very beginning of this researching on this topic, but I think I would be remiss to not mention this article that just came out from our group highlighting some of these issues and research we could address in the arthritis care and research in December 24. But one of them is older adults are missing from rheumatologic clinical trials, right? So you and I are making decisions and giving them advice on something that was not even covered in the trial, right? That I'm extrapolating data from. So they are first of all excluded from clinical research. Even observational studies have very young age limit for and being inclusive of patients. So I think the first thing just to as a room community to recognize is that with our aging population increasing, we need data that will cover these older adults. And that needs to come from like maybe clinical trials. And one framework really important to highlight is the 5Ts framework. So not 5M, the 5Ts framework. It was developed by Dr. Bowling and was presented at the AGS meeting in last year, 24, where the 5Ts stand for target population, team, time, tips to accommodate, and tools, where how we can increase the representation of older adults in clinical trials, either for geriatrics or rheumatology. And I think it is mentioned in some more detail in our article, but would be a very important framework to go by. And then in terms of what research is coming or is in the pipeline, if I were to name my friend's name from the Geri Rheumatology, we will fall short of time for sure. But to just at least name a few, Dr. Jiali, Dr. Katie Weisham, Sebastian, Sarah Lieber, they're all working hard on some of these questions and with a lot of mentorship to all of us from Dr. Una McCrease. So there's a lot coming in the pipeline, and we envision growing as a community as a whole.
Can you talk a little bit about how people that may be interested in geriatric rheumatology can get involved? Like, what sort of groups does the ACR have, and what other opportunities are there for people interested in this field?
This is maybe my favorite question. Yes, please. If you're interested in geriatric rheumatology, please contact any of us that maybe the names are harder to catch when I said it so fast, but you can start with us. But there's the Geri Rheumatology group that is led by Jihali and Dr. McCrease. We meet on a monthly basis, and the group is growing from where it started. So that's amazing to see. And any of us would be very interested. It's just a Zoom call. You get on a Zoom call with us and you bring what is that you want to study. What are you gravitating towards? And we all pitch in to help and make sure your project becomes actual, can get data around it and get more published on the topic. So I think that would be the first start, is getting involved in the Geri Rheumatology group, and eventually then maybe the Geriatric Society meeting that we attend. And then there are some special interest groups from the AGS, like frailty has a special interest group, inflammation has where inflammaging comes in, some special interest groups of interest to you. And that's just the tip of the iceberg.
Great. So if you can provide us with those links and also the article that you guys published, we can put it on the show notes so that listeners can go back and access some of that information. Namrata, it's been awesome speaking with you and catching up. It's amazing to see everything you've done to try to improve the management of older adults, not only for the research that you've done, but certainly for the education that you've done at the ACR and certainly here today. So I really applaud your work and hope that you continue doing what you're doing for
Thank you
years to
so much.
come. Thank you so much.
Jonathan, thank you so much for having me. It's been such a treat to be here and talk to you today. Really, thank you for bringing this topic to ACR on air.
Well, there you go. Everything you ever wanted to know about caring for older adults, but were afraid to ask. We certainly covered a lot of material that should improve the way that we treat this growing population in our rheumatology clinics. Dr. Singh emphasized the importance of recognizing frailty and multimorbidity, as well as the need for careful medication management and for incorporating palliative care principles into our practice. We also discussed the critical gap in clinical trials, where older adults are often underrepresented. Despite these challenges, Dr. Singh's team-based, patient-centered approach has the potential to make a profound difference in the life of older adults. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this and other episodes at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, let's all focus on what matters most, both for us and for our patients. And of course, stay healthy.